So today we would focus on portocaval anastomosis. Portocaval anastomosis. And from the word portocaval anastomosis, we hear portal, which is portal vein or portal venous system, and caval, which is vena cava. And then anastomosis is just the connection between blood vessels. So the portocaval anastomosis is the connection or the anastomosis between the portal system or the portal vein and the vena cava. We know that in normal circulation, general circulation, blood returns to the heart through the vena cava, superior vena cava and inferior vena cava. So body organs and tissues are drained by different veins, and these veins all join the inferior and superior vena cava to return the blood to the heart. Now, that is systemic circulation. But we also know that there is a portal circulation that involves a portal vein. And this portal vein receives blood from digestive organs like the stomach, the intestines, and of course, the spleen, and return and take that blood to the liver first. So that blood doesn't go to the heart directly. It doesn't go to the inferior vena cava directly. It first goes to the liver. Now, why is that blood going to the liver? It is because digested food from your digestive system might contain some toxins or some toxic substances, and the liver is the organ that detoxifies, the blood. So what happens is that blood from the digestive system containing digested food must first go to the liver through the portal vein. And then after detoxification, the liver and metabolism of some of the digested food product, the liver then releases that blood into the hepatic vein that now goes to the vena cava. So that is why we have two systems, a systemic venous return and a portal venous system. So the portal venous system exists only because we don't want to remove blood from the digestive system and then send it into the general circulation. If there is a toxin or something toxic in that blood, it might now circulate to every other part of your body. But to prevent that, we need a portal system whereby blood from digestive organs would first go to the liver, and then purification of that blood will take place, or detoxification, before the blood now goes to the general circulation and enters the vena cava and then goes to the heart. So, but today we want to see what happens if that portal system is obstructed. If something obstructs the portal vein and blood can no longer pass through the portal vein to the liver, what will happen to our circulatory system or our venous return? But before we delve into details, let's do a little revision about the portal system. So the portal circulation, what happens in the portal circulation? Blood is collected from one set of capillaries and is passed to a larger vessel, which then again divides into capillaries before the blood is returned to systemic circulation. So what this simply means is that blood leaves the digestive system and then enters into the portal vein. And then from the portal vein, the blood goes to the liver. And then from the liver, after detoxification, the blood goes to the hepatic vein, and then it goes to the heart. So that is what I'm trying to say here. because you know the junction before blood leaves, when blood leaves one organ to another organ, there has to be some capillary beds, which we already discussed in the previous classes. So now, portal vein. So this is the portal vein. Here you see the hepatic portal vein, it's blue vessel here. Remember this? Good. Now, and here you see the liver here. You see the portal vein splitting into a right and a left branch here. But this portal vein, we said before that it is formed from a union of the superior mesenteric vein, which is this one, superior mesenteric vein, okay, and splenic vein. So the splenic vein, this is the spleen here, the splenic vein and the superior mesenteric vein anastomose or join or unite to form the portal vein or the hepatic portal vein. Remember, our inferior mesenteric artery joins the splenic vein. It does not unite directly to form the hepatic portal vein. So only two vessels. Although some textbooks say that it is a combination of splenic vein, inferior mesenteric vein, and superior mesenteric vein. But what actually happens is that inferior mesenteric vein first joins splenic vein, and then splenic vein together with superior mesenteric vein now form hepatic portal vein. Now, so what are the tributaries of the portal vein? Where does blood come from, to enter into the portal vein? So here you see the tributaries of the portal vein, the left gastric vein. So we're talking about the stomach here, the right gastric vein, talking about the stomach. So here you see the left gastric vein and the right gastric vein here, both of them. So you see they're entering the portal vein also. And then here you see the cystic vein coming from the gallbladder, all right, from the gallbladder, which is attached to the liver, also joins the portal vein. And then we have the posterior superior pancreatico duodenal vein, which is this one, posterior superior pancreatico duodenal vein, coming from the pancreas and the duodenum. So also joins the portal vein. So these are the tributaries of the portal vein, and you will realize that most of them are digestive organs. So this left gastric, right gastric, stomach, cystic, gallbladder, where the bile is stored, right? And then posterior superior pancreatico duodenal vein, the pancreas, containing pancreatic juice, and then the duodenum also, where part of the small intestine where digestion takes place. So all of these blood, right, are returned to the portal vein. So this is portal vein. This is portal venous system. Now, the portal vein runs almost vertically upward in the free margin on the lesser omentum. So I think we already did this before. So they're just showing us the position of the portal vein, and then anteriorly it is surrounded by the pancreas and the first part of the duodenum. So here you see your pancreas and the first part of the duodenum is not actually shown, properly shown in this picture. And then posteriorly, it is surrounded by the inferior vena cava, okay, between two layers of the lesser omentum. Now, the hepatic artery and the common bile ducts lie in the same plane and in front of the portal vein. Hepatic artery, common bile ducts, and portal vein. You know, we talked about the portal triad in the previous lecture. Okay, so hepatic artery, common bile duct, and the portal vein lie on the same plane. So here you will see the three of them here. Good. Now, but our what we're interested in this lecture today is the portocaval anastomosis. So the connection between the portal system, and the caval or the vena caval system. Now, you need to pay attention to this because this is very important. There is something called portal hypertension. And so if you don't understand this connection here, you will not understand what happens in portal hypertension. So what happens? Portocaval anastomosis simply means that there is a connection between the portal system and the caval system. And there are 5 main locations where this anastomosis occurs. Now, where are these locations? So the first location where the caval system anastomose with the portal system is at the lower third of the esophagus, at the lower third of the esophagus. Remember, when we were talking about the stomach, we mentioned that this part of the stomach, the upper part of the stomach here, where that is labeled A, this place, we talked about that we have what we call the short gastric veins, right? The short gastric veins. So what happens in the lower third of the esophagus is that there is an anastomosis between short gastric veins that are draining the stomach. Remember that we said that the digestive organs are parts. They drain into the portal system, yeah? Digestive organs drain into the portal venous system. So it means that our short gastric vein is supposed to drain into the portal vein, okay? But apart from the short gastric vein draining into the portal vein, it can also be drained by what we call the esophageal vein. So we have the esophageal vein, but this esophageal vein drains into what we call the azygos vein. So the esophageal vein drains into the azygos vein. So what happens is that the left gastric vein, which is part of the portal system, drains into the azygos vein, which is part of the systemic circulation or the caval system. So this azygos vein is supposed to drain. It drains into the vena cava, while the short gastric vein is supposed to drain into the portal system. But there is a connection between this azygos vein from the caval system or the vena cava that's supposed to drain into the vena cava, and the short gastric vein, which is supposed to drain into the portal vein. So that's why we call it portocaval anastomosis. So at this junction, what happens is that left gastric vein anastomose with azygos vein. So that is the first point where portocaval anastomosis occurs. Azygos vein draining esophagus into vena cava, short gastric vein draining stomach, upper part of stomach into portal vein. But there is a connection between the both of them. So this is where the anastomosis takes place. Okay, now here you see esophageal vein. So this esophageal vein is a branch of the short gastric vein. So when you see esophageal vein here, it's the same thing, left gastric vein, I beg your pardon, of the left gastric vein. So this esophageal vein you see here is a branch of the left gastric vein. So here you see the left gastric vein, the left gastric vein, and this esophageal vein is like a branch of that left gastric vein, which anastomoses with the esophageal branch of the azygos vein. So what happens is that left gastric vein has esophageal branch and azygos vein has esophageal branch. So both of them anastomose, right, to form this anastomosis in this area. So the first part, the first place where portocaval anastomosis occurs is in the esophageal region or the lower third of the esophagus, and the vessels involved are the left gastric vein and the azygos vein. Left gastric vein and the azygos vein. So this esophageal vein is just a branch, okay? But the main vessels involved in that anastomosis are the left gastric vein and the azygos vein. Now, the second part where there is anastomosis between the portocaval system is in the para-umbilical area. Para-umbilical area. So here, this is the para-umbilical anastomosis, labeled here as C. So what happens here? Now here you find this para-umbilical vein. So this para-umbilical vein is a part of the portal system. But para-umbilical vein is part of the portal venous system. It drains into the portal vein. So that's why you can see it coming from here like this. So this is the portal vein. This is the right and left branches of the portal vein. From this left branch of the portal vein, you see this vein coming here. So this is called the para-umbilical vein. Then this para-umbilical vein from the portal system anastomosis with what we call superficial epigastric vein. So you see these two veins here, we'll call them superficial epigastric veins. And these veins are coming from the, so here you have your common iliac vein, and you have your internal iliac and your external iliac vein. So these ones are coming from this common iliac vein, or you could say the iliac veins, and they are part of the caval system or caval venous system. So this epigastric vein from the caval venous system, superficial epigastric vein from the caval venous system, anastomose with the para-umbilical vein from the portal system. So here we have a portocaval anastomosis. So this is happening around the umbilicus, yeah, around your navel. So around this para-umbilical area, para-umbilical vein anastomose with superficial epigastric veins. And this happens in the anterior abdominal wall, just close to your umbilicus. Now, the third part or the third location for a portal caval anastomosis, another name for portal caval anastomosis, portal systemic anastomosis, okay? So because the caval anastomosis or the caval venous system is a part of the systemic circulation. So that is why it is called portal systemic or portal caval. Now, the third place where there is an anastomosis between the portal venous system and the caval system is around the anus or the upper end of the anal canal. So here, this is the anus. So around the upper part of the anal canal, you will see anastomosis. Now here, this one in blue or purple color, if you will, is the superior rectal vein. So this superior rectal vein, because it is blue, you can see that it drains into the portal system. I think we mentioned this in our previous lecture. So the superior rectal vein drains into the portal system. So it's part of the portal venous system. Now, it anastomosis here with the rectal veins, middle rectal and inferior rectal vein. So inferior rectal and middle rectal veins are part of the systemic circulation or the caval system. So inferior rectal and middle rectal veins anastomose with superior rectal vein. So superior rectal vein is part of the portal system, while the middle and inferior rectal veins are part of the caval system. So here we have a portocaval anastomosis also. Now, there is also two other anastomoses which are not as important as the first three that we already mentioned. So here at this place, D, you will see we have what we call a retroperitoneal area. So we have the retroperitoneal area. There we have your kidney. Okay, so your kidney is there. Now there is an anastomosis between the colic vein. So remember that colic vein, because it's in blue color, yeah, colic vein from the colon, yeah. So we have the ascending colon, transverse colon, and the descending colon and the sigmoid colon. So these veins are part of the portal system. Now they anastomose with some retroperitoneal organs like the kidney, so your renal vein. Okay. Now, such anastomosis is also called a portocaval anastomosis because it's a combination of veins from the portal system and veins from the systemic or caval system. And then there is also a fifth anastomosis, which is not very, very important within the bare area of the liver. So let's quickly remember this. So 5 sites of portocaval anastomosis, 5 sites of portocaval anastomosis. The first part is the lower third of esophagus. Second place is at the para-umbilical area. The third place is the upper end of the anal canal. And then the fourth place is the retroperitoneal region, and then at the bare area of the liver. Now let's see. So what happens at the lower third of the esophagus? At the lower third of the esophagus, the esophageal branches of the left gastric vein, which is from the portal tributaries, from the portal venous system, anastomose with the esophageal veins draining the middle third of the esophagus into the azygos vein. So azygos vein is part of systemic tributaries or superior vena cava. So what do you need to know? That at the lower third of the esophagus, we have left gastric vein anastomosing with azygos vein. Left gastric vein is from the portal venous system, while the azygos vein is from the systemic blood circulation or the caval system. So that is what happens at the lower third of esophagus. Now, secondly, in the para-umbilical area, there is a connection between the left branch of the portal vein with the superficial veins of the anterior abdominal wall. So the left branch of the portal vein gives the para-umbilical vein, which anastomose with the superficial epigastric veins, as we said here. So para-umbilical vein coming from left branch of portal vein, anastomosing with superficial epigastric vein that are coming from the common iliac or the internal and external iliac veins. So that's what happens in the para-umbilical region. Left branch of portal vein, anastomosing with superficial epigastric vessels from the external iliac and internal iliac veins. And then in the anal region, the anal canal, we have the superior rectal vein, which is part of the portal tributary or the portal venous system, draining the upper half of the anal canal. It's anastomosis with the middle and inferior rectal veins. So the middle and inferior rectal veins are tributaries of the systemic circulation. So they are supposed to drain into the vena cava, inferior vena cava. Now, which are tributaries of the internal iliac and internal pudendal veins, respectively. So that's what happens in the anal canal. Now, the next region is the retroperitoneal region. So what happens there? The veins of the ascending colon, descending colon, duodenum, pancreas, and liver, which are part of the portal tributary, portal venous system, anastomose with the renal, lumbar, and phrenic veins, which are part of the systemic circulation or caval system. So that's what happens in the retroperitoneal area. So these organs, renal, lumbar, and phrenic veins are retroperitoneally located. So they anastomose with ascending colon, descending colon, duodenum, pancreas, and liver. So the vessels coming from there. Well, you just see the colic vein. Now, the bare area of the liver, there is some anastomosis between the portal venous channels in the liver and a zygos system of veins above the diaphragm across the bare area of the liver. But like I said, this anastomosis does not really have any clinical important. So most textbooks don't talk about it. But the first four, especially the first three, are very important anastomosis. Now, so here again, you see the diagram. Let's try to locate the parts of the portocaval anastomosis. Now, we said that there are 5 regions. So from this diagram, let's try to locate them. We said the first anastomosis is here at the lower third of the esophagus, or the upper part of the stomach, where you have tributaries of the zygous vein anastomosing with left gastric vein. So that is the first part where the anastomosis occurs in the esophageal region. And then also we said that we have another anastomosis in the para-umbilical region, where para-umbilical vein coming from the left branch of the portal vein, anastomosis with superficial epigastric veins. That was not labeled here. Okay, but okay, here. Yeah, so superficial epigastric veins are supposed to anastomose with the para-umbilical vein to form the portocaval anastomosis around the umbilicus. And then we have at the anal region. At the anal region, we have the superior rectal vein, which is part of the portal system, anastomosing with middle and inferior rectal veins, okay, to form the portocaval anastomosis around the anal canal or the anus. And then the fourth one we said is the retroperitoneal region, where the colic veins anastomose with veins of the kidney, right? The kidney, the lumbar region, and the phrenic vein. So that is the fourth anastomosis. And then there is another anastomosis within the bare area of the liver. Okay, this is number 5, some branches of the vena of the portal vein anastomosing with some part of the zygous vein, but that is not properly labeled here in this diagram. So these are the 5 places where portocaval anastomosis occurs. What do you need to know? You only need to know the names of the veins that are systemic and the ones that are portal. So for the first part around the esophagus, the systemic vein is the zygous vein, while the portal vein, or the one that will join into the portal system, is the left gastric vein. Okay, left gastric vein. Around the para-umbilical region, the vein from the portal system is the para-umbilical vein, while the vein from the systemic or caval system are the superficial epigastric veins. Then around the upper end of the anal canal, the portal vein is the portal tributary is the superior rectal vein, while the systemic or caval tributaries are the middle and inferior rectal veins. And then around the retroperitoneal area, the systemic or the portal vein, venous tributaries are the colic veins, while the systemic veins are the renal veins, the lumbar veins, and the phrenic veins. And then here we have in the bare area of the liver, we have anastomosis between some branches of the portal vein and phrenic vein, or hemizygous vein. Okay, so let's see what happens. Portal hypertension. So this is what is important to us. This is the most important aspect of this lecture. So what is portal hypertension? Portal hypertension is defined as increase in blood pressure in the veins of the portal system. Increase in blood pressure in the veins of the portal system caused by obstruction in the liver And this obstruction could be as a result of liver cirrhosis, thrombophlebitis, which cause enlargement of collateral veins and splenomegaly. So what are we talking about? We are saying that sometimes the blood pressure in the portal venous system could increase. And what could lead to that increase? One, if there is liver cirrhosis. Okay, so this is the liver. Looks like a normal liver, and this liver looks like a liver with a destroyed parenchyma. Now, if there's liver cirrhosis, the liver tissue is destroyed. It becomes hard and can no longer function. So what happens is that blood can no longer go to the liver because the liver cannot function. This liver tissue is destroyed. So that's what we call cirrhosis, liver cirrhosis. So it means that blood cannot pass through this portal vein into this liver. So what will happen if blood cannot go to the liver? We need to look for a way to remove that blood or to prevent that blood from going to the liver. So what happens? If blood was supposed to go upward in this direction into the liver, but now the blood cannot go because there is destruction of the liver tissue, the blood flows backward into the splenic vein, into the inferior mesenteric vein, into the superior mesenteric vein. And what will happen? The blood will gather in this blood vessels, in this portal system. So they will be filled with blood. And because they are filled with blood and the blood cannot pass through the liver, the blood pressure in these vessels will increase. And that will lead to what we call portal hypertension. Portal hypertension. So portal hypertension means an increase in blood pressure in the portal venous system, not only in the portal vein, but in all the veins that make up the portal venous system will have an increased blood pressure. Why? Because blood is gathered inside these blood vessels, but the blood cannot be channeled through the liver and then to the hepatic vein and then to the inferior vena cava. It cannot. So that will lead to an increase in blood pressure. Let me take you back a little. So look at this diagram. Now look at this diagram. So here, these are portal, everything you see in purple color is the portal venous system. Now, all this blood in this purple color are supposed to enter this portal vein, and then from the portal vein, they enter into the liver, and then leave the liver through the hepatic vein into the vena cava, right, inferior vena cava. But now, the liver cells or tissues are destroyed, and the blood cannot pass through this liver anymore. So, and if the blood cannot pass through the liver, it means the blood cannot get to the hepatic vein. And if the blood does not get to the hepatic vein, it means it cannot get to the inferior vena cava. So what happens? The blood will have to flow back into these purple vessels, this portal system. And that will mean that there will be increased blood volume in this portal system, and that will lead to increased blood pressure in the portal system, which is what we call the portal hypertension. Do you understand that?
Yes, sir.
Okay, good. Now, so in portal hypertension, blood cannot pass through the liver. The portal system is filled with blood, but this blood cannot pass through the liver to go to the hepatic vein and the inferior vena cava. So the blood has to flow back into splenic vein. And what that means is that if blood is flowing back to splenic vein, it means it will be difficult for blood to even leave the spleen into the splenic vein because the blood is already draining back. So that could lead to splenomegaly. So the spleen will become bigger in size because it cannot be drained. Blood cannot leave the spleen. Why? Because there is a backflow of blood into the spleen, into the splenic vessel. The same thing would happen in the backflow of blood into the inferior mesenteric vein. the backflow of blood into the superior mesenteric vein, right? And of course, we had said that the left gastric vein formed an anastomosis with a zygous vein. So what will happen? 1 minute. Now, there are two types or two things that can cause portal hypertension. One is liver cirrhosis, so we'll call that intrahepatic cause of portal hypertension. And then we'll have thrombosis of the portal vein, which is extrahepatic. So the portal vein can be blocked by thrombus around this place. So the problem is not with the liver. We might have a functional liver, a good liver that is functional. There is thrombosis of the portal vein, which blocks blood flow through the portal vein. So that could be an extrahepatic cause of portal hypertension. Okay, so what will happen? What are the consequences of portal hypertension? How will you know that a patient has portal hypertension? You will see the following 5 things. One is called esophageal varices. Esophageal varices. Remember that we said that there is an anastomosis between esophageal branches of left gastric vein and esophageal branches of a zygous vein. So if there is portal hypertension, I take you back to this diagram again. If there is portal hypertension, blood cannot drain to the portal system. So what will happen? It means that the azygous vein or the esophageal branch of the azygous vein will be filled with blood because the blood cannot come to the portal system. So it means that there will be too much blood pressure, increased blood pressure around the esophagus, and that will cause dilation of the esophageal region. And we'll have what we call the esophageal varices. Esophageal varices. Sometimes if the pressure becomes too high, it could even lead to bleeding from the esophagus. So remember that if you see a patient that is bleeding from the esophagus, you could suspect that this patient has portal hypertension, but only that is not enough to diagnose portal hypertension. So if the patient is bleeding from the esophagus because there is the veins there have they are dilated because of too much blood, you suspect portal hypertension. But there's another thing, another sign for portal hypertension, which is called caput medosa. So let me see if I can show you caput medosa. Okay, so caput medosa occurs around the anterior abdominal wall, around the umbilicus, because we said that there is an anastomosis between the para-umbilical vein and the superficial epigastric vein around the anterior abdominal wall, close to the umbilicus. So the blood pressure there will increase also if there is portal hypertension. And you will see the veins around that place will form what we call a caput medosa. You will see it in a diagram I will show you soon. And then we'll have hemorrhoids. So hemorrhoids, the patient will have some bleeding from the anus, because we said that there is an anastomosis around the anal canal between the superior rectal vein and the middle and inferior rectal veins around the anus. So the blood pressure there will increase also because of the too much blood there, because the blood that was supposed to go to the portal vein cannot go, and so blood gathers there, and that could lead to hemorrhoids. And then we have ascites, whereby fluid, venous blood is gathered around the anterior abdominal wall, and that will have ascites. And then we'll have splenomegaly because the splenic vein can no longer drain blood into the portal vein because there is a backflow of blood. So the portal vein is blocked. There's a backflow of blood to the spleen, and then there'll be splenomegaly. So here you see how varicose veins. So these are the veins. They are filled with blood. These veins are filled with blood and blood at high pressure because the blood cannot be drained to the portal vein. So what happens is that all the blood gather. So this is your stomach here. This is your esophagus. So these are esophageal varices, varicose veins. And because of these varicose veins, if the pressure becomes too much, they could begin to bleed, and you have what is called hematemesis, whereby the patient could vomit blood. Okay, so hematemesis, as the patient vomits blood, and sometimes you see black tarry stool. So the feces also contains blood. Okay, now it can be visualized using endoscopy. So with endoscopy, you can view the esophagus and the upper part of the stomach, and you will see that the veins are dilated because of the volume, high volume of blood in them. So this blood cannot flow into the portal vein. And so that leads to esophageal varices. So esophageal varices is a result of portal hypertension at the first region of portocaval anastomosis. Now, caput medosa. So caput medosa is as a result of portal hypertension in the paraumbilical region. So this, you see this here, these are dilated veins, which we call caput medosa. And this anastomosis here, we said it is anastomosis between the paraumbilical vein and the superficial epigastric veins. Portal system, caval system. But now we cannot drain the blood into the liver and then into the hepatic vein and inferior vena cava. So the blood gathers around the umbilicus. So this is what we call caput medosa. So if you see a patient with caput medosa and the patient vomits blood, you should suspect portal hypertension already. And you should suspect liver cirrhosis also, because liver cirrhosis leads to portal hypertension, or thrombophlebitis of the portal vein could also lead to portal hypertension. So if they ask you in an exam, which anastomosis is responsible for caput medosa, so you will say it's the anastomosis between the paraumbilical vein and the superficial epigastric veins. Which anastomosis is responsible for esophageal varices? You say it is the anastomosis between the azygos vein and the left gastric vein. Okay, good. So caput medosa, this is how it is. Now, hemorrhoids. So hemorrhoids are painful swollen veins in the lower portion of the rectum or anus. And then because of that, you see blood in the feces, fresh blood in the feces. So here, these are the veins, the hemorrhoids. These are the hemorrhoids, enlarged, swollen veins due to excess blood. Blood that was supposed to drain into the portal vein cannot drain into the portal vein because there is portal hypertension. So there's a backflow of blood. So the blood gathers here, where we have anastomosis between the superior rectal veins and the middle and inferior rectal veins. So that is what happens. And then you have hemorrhoids. When the person goes to the toilet, you see that blood-stained feces will be passed out. And then ascites. So ascites is accumulation of fluid in the peritoneal cavity. And it as a result of the retroperitoneal anastomosis, which we said is between veins from the ascending colon, transverse colon, anastomosing with veins from the kidney, the lumbar region, and the phrenic and the diaphragm. Now, so this anastomosis is responsible for ascites. So ascites is the collection of fluid. You see excess fluid will gather in the anterior, in the abdominal wall. You see excess fluid will gather in the abdominal wall. So that is also a sign of the patient with liver cirrhosis or with portal hypertension. So remember that. Now, treatment. So before we go to treatment, let's quickly review the signs of portal hypertension. How do you know that a patient has portal hypertension? So we said the first sign would be esophageal varices. The second sign is caput medusa. The third sign is hemorrhoids. The fourth sign is ascites. And the fifth sign is splenomegaly. Esophageal varices. Why? Because of the anastomosis between the azygos vein and the left gastric vein, left gastric vein. And the pressure there is increased because blood cannot pass through the portal vein. And then the caput medusa is the second sign of portal hypertension, and it is because of the anastomosis between the paraumbilical vein and the superficial epigastric veins. So we have the dilation of the blood vessels around the umbilicus, forming what we call the caput medusa. And then we have the hemorrhoids, which is as a result of the anastomosis between the superior rectal vein and the middle and inferior rectal veins around the anus or the anal canal. And that will lead to bleeding of feces stained with blood. And then we have ascites, which is fluid collection in the peritoneal cavity. And we said that there is a retroperitoneal anastomosis between blood vessels from the colon, ascending and transverse colon, anastomosing with the kidney and the lumbar region. And then we have splenomegaly, which is because of the splenic vein, which cannot drain into the portal vein. And so there's a backflow of blood into the spleen, and that leads to splenomegaly. So these are the signs of portal hypertension. Now, treatment. How do we treat portal hypertension? So we have what is called band ligation, sclerotherapy, portosystemic shunt, and transjugular intrahepatic portosystemic shunting. So what do we do with band ligation? So in band ligation, a small band is applied to the base of the varix, stopping blood supply to it. So we want to stop blood supply to that region. Since we cannot drain the blood from that region, there's no point sending blood there. So around the esophagus, where the varicose veins are, we put a band to prevent blood from coming there. And when blood does not come to that varicose region, so you see these varicose veins, when we stop blood from going there, what will happen is that it will shrink and die within a few days. And the dead tissue along with the band will fall off during normal peristaltic movement. So when food is passing through the esophagus, the dead cells that fell from the varicose veins will fall off during peristaltic movement. So this here you see this is like a banded varicose. So that is how you treat the esophageal vein. Another esophageal varicose. Another method is sclerotherapy. So in sclerotherapy, you take a solution of sodium and ethanolamine, introduce them into the varix, and then that will obliterate or destroy the varicose veins. That will destroy the varicose vein. And then there would be submucous fibrosis. So it will become hard and thickened. And after some time, it will, because the blood vessels are no longer, the blood is no longer gathered there because it's been completely removed through the sclerotherapy. And then another way is portal systemic shunts. So what you want to create a shunt between the portal system and the systemic or the caval system. So a common method for reducing portal hypertension is to divert blood from the portal venous system to the systemic venous system by creating a communication between the hepatic portal vein and the inferior vena cava. So now this is an artificial shunt we are going to create now. This shunt was not there before. Normally what happens is that from the portal vein, the blood is supposed to enter the liver, and then from the liver it enters the hepatic vein, and from the hepatic vein it goes to the inferior vena cava. But now the blood cannot pass through the liver. So what we need to do, we need to create an artificial shunt that connects the portal vein directly with the inferior vena cava. So look at this diagram here. Here you see this purple color is portal vein, and this blue one is inferior vena cava. So you see there's a connection now. Instead of this blood vessel joining or being continuous, the two purple being continuous, what we did, because blood cannot pass through this place, so we divert blood from this portal system directly into the inferior vena cava. So we have end to side and side to side. So for side to side, you take a side of the portal vein with a side of the inferior vena cava, you create a connection between them. Or you take one end of the portal vein and connect it to the side of the inferior vena cava, so that blood does not need to go through this portal system anymore. And you know that once you do this anastomosis, blood will no longer flow back into the splenic vein. Blood will not flow back into the splenic vein. The blood will enter directly into the inferior vena cava, where it will be taken to the heart. But if we don't do this anastomosis, what will happen is that blood will flow back into the splenic vein, into the superior mesenteric vein, and into the inferior mesenteric vein, and cause a high pressure and cause portal hypertension. So to prevent that portal hypertension, we do a shunt, an artificial shunt, to connect the portal vein directly into the inferior vena cava. So the blood does not need to pass through the liver. But you know, the danger, or I would say, this danger, the little side effect is that now this blood in this portal venous system will no longer be detoxified, because the blood was supposed to go to the liver to be detoxified, but now the blood cannot go to the liver. The blood is going straight into the inferior vena cava. From the inferior vena cava, you need to go to the heart, right? So some toxins might enter the systemic circulation. Another way of reducing portal pressure is to join the splenic vein to the left renal vein after splenectomy. So what is that? It is called splenorenal anastomosis. So you connect the splenic vein. Remember, splenic vein is supposed to drain into portal vein, and then into portal vein. But now, because portal vein has too much pressure and the blood cannot pass through the portal vein, what we do, we'll create a shunt between the splenic vein to the left renal vein, because from the left renal vein, the blood can enter inferior vena cava, because the renal vein is not part of the portal system. It is part of the systemic or caval system. That's another way to reduce the portal hypertension. Then we have transjugular intrahepatic portosystemic shunting. So this is an artificial channel within the liver that establishes communication between the inflow portal vein and the outflow hepatic vein. Remember that we said it's the hepatic vein that's supposed to drain the liver, but the blood must first come from the portal vein into the liver, and then from there, you drain it. So in this transjugular intrahepatic portosystemic shunting, what we do is that we establish communication between the inflow portal vein and the outflow hepatic vein. So this procedure is done by catheterization of the right hepatic vein via the internal jugular vein. So here you are trying to connect the hepatic vein with the inferior vena cava, but you create a connection between the internal jugular vein and the right hepatic vein and the right hepatic vein. Now that could also decrease the hypertension, because sometimes portal hypertension could be caused by a thrombosis of the hepatic vein itself, not the portal vein. The hepatic vein itself could be thrombosed. And you know, if there is thrombosis of the hepatic vein, it means that blood cannot leave the liver. The liver cannot be drained. And what will happen? It means that there could be a backflow into the portal system. So that could happen sometimes. And that would be a kind of post-hepatic cause of portal hypertension. Post-hepatic cause of portal hypertension. So these are the ways, but what they will ask you in exam mostly, they might not really ask you about this treatment. What you need to know are the signs of portal hypertension, which we said are the esophageal varices, caput medusa, hemorrhoid, ascites, and splenomegaly. So these are the main signs. And you must remember all the places where anastomosis took place. 5 areas of anastomosis, you must remember them, and which vessel is involved in that anastomosis. Yeah, so this is portal hypertension and portocaval anastomosis. Any exam you want to write, USMLE, CLAB, any exam, you are going to be asked questions about portocaval anastomosis and portal hypertension. Okay, good. Do you have any question?
No, sir.
Okay, good. Thank you so much. See you in the next lecture. Bye.
Yes, sir.